My name is Hannah Murphy. I am with Vizient and I work within the Research Analytics and Insights group. Together, we work with Vizient members who want to leverage Vizient clinical database and other data sources within Vizient aimed at academic presentation and publication. And this work kind of spurred from that. I originally presented this at the American Public Health Association annual meeting, and I'm excited to share it. So using the Vizient clinical database, we identified a little over 19 million pediatric emergency department encounters among children aged 2 to 17, discharged between 2018 to 2023. Among these, a little over 700,000 or 4% had diabetes. And among those, 200,000 or 27% had diabetes with a concomitant mental health disorder, compared to only 12% among those without diabetes. And so from there, what we did was we developed a multivariable logistic regression model predicting diabetes status and separately predicting mental health disorders among those with diabetes. What we found was that older age, Medicaid payer status, and higher vulnerability were significantly associated with having diabetes and also having a mental health disorder among those with diabetes. So these findings really underscore the need for providers to treat mental health as a routine component of pediatric diabetes care rather than a separate or downstream issue. Yeah, so like I said, in our analysis of nearly 19 million pediatric ED encounters, we found that 1 in 4 children with diabetes also had a documented mental health disorder compared to 1 in 9 without diabetes. So this really tells us this is not a small subgroup issue. It's a major part of pediatric diabetes care. And for many children and adolescents with diabetes, the emotional and behavioral burden is part of the disease experience itself. So, managing diabetes really requires constant decision making. It requires monitoring, family support, having access to care, and all of this can be really incredibly stressful. So, I think what this suggests within our current systems is that we're still too siloed. We often treat medical conditions in one setting and mental health disorders or mental health in another setting, but what these children really need is integrated care. And so, these pediatric visits, whether it's in primary care or in an ED or high acuity setting, really should include this routine attention to mental health instead of addressing these issues when they become acute. Yeah, so I really think this finding should get everyone's attention. It was one of the more striking findings in our analysis itself. So it doesn't necessarily mean that every child with diabetes who also has some sort of mental health diagnosis is in crisis. But what it does mean is that pediatricians really should take this suicide risk seriously and normalize screening as part of the routine care. So in everyday practice, what I think this means is using standardized, validated, and age-appropriate screening tools and asking directly about depression, anxiety, self-harm, and suicidal thoughts. But it also means having a clear workflow for what happens when a child screens positive. So we know that screening is most effective if there is a clear plan behind it. And so that can and really should include same-day risk assessment when it's needed. It should include warm handoffs to behavioral health, crisis resources, family engagement, and really importantly, close follow-up after the fact. So the key message here is that pediatricians do not have to manage this alone, but they do need reliable systems to identify risk early and connect patients to support quickly. Yeah. So as you mentioned, we found that older adolescents, particularly those 15 to 17, really showed some of the highest risk in our analyses. We know that adolescence is already a challenging developmental period for so many reasons, and for children with these chronic diseases, it's kind of that added pressure of managing this complex disease while also navigating adolescence itself, which can include school, peer relationships, etc. So I think where pediatricians really come in is helping to create developmentally appropriate care environments. So specifically during their visits, having open conversations about stress and burnout, and really, like I mentioned before, that consistent screening of risk. For patients with Medicaid coverage or higher social vulnerability, the practical, albeit tough, response is to reduce barriers to care. So, this may include connecting families with care coordinators, social workers, providing transportation, food, housing support, school-based supports. There's a lot of research kind of around community involvement. And then importantly, incorporating behavioral health that accepts their insurance. We know it's becoming increasingly more tough, but finding coverage that accepts their insurance, I think, is really, really important. It also means recognizing that these missed appointments or children with poor glycemic control, that it may reflect kind of barriers to access rather than a lack of motivation. The broader point is that this risk is not necessarily only clinical. Social needs and access to care kind of play a major role in whether families can manage diabetes over time or not. Yeah, I think that's a great question. And so, like you mentioned, in our study, anxiety disorders and mood disorders were among the most common conditions that we saw with children with diabetes, but behavioral and emotional disorders were also kind of consistently more common in those children with who had diabetes versus those without. And so I think at a minimum, pediatricians should be consistently screening for depression, anxiety, and distress related to the disease management and the burden there. But additionally, suicidal ideation, self-harm, and then importantly, substance use, especially in those kind of older adolescents. Um, Behavioral and emotional concerns are important, particularly when they begin affecting diabetes management, school functioning, sleep, family relationships. But I think importantly, I would emphasize the screening should not be a one-time event. We know that mental health needs change over time in adolescence as a whole, but then also particularly at times when there's a diagnosis milestone, if there's a complication or a transition to care. The most effective approach is routine, normalized screening that's built into this care with a clear referral follow-up pathway when concerns are identified.